Hello, everyone. I'm Ken Warrington, a rheumatologist at the Mayo Clinic in Rochester, Minnesota, and it's my pleasure to present our abstract titled Exome Sequencing May Not Be Suitable for the Diagnosis of Deficiency of Adenosine Deaminase 2. The purpose of this abstract is to report on an individual who was given a diagnosis of polyarteritis nodosa in childhood, but presented in adulthood with clinical features suggestive of deficiency of adenosine deaminase 2. He underwent exome sequencing, and this only detected a single pathogenic variant, resulting in a delay in his diagnosis. However, subsequent genetic testing revealed a single exon deletion, and biochemical assay confirmed deficiency of adenosine deaminase 2. In getting to the clinical case, this was a 32-year-old gentleman who was referred to rheumatology for evaluation of recurrent ischemic cerebral infarcts and persistent but intermittent low-grade fever. In childhood, he had presented with a fever of unknown origin, aphthous oral ulcers, joint pain, and new onset hypertension. He underwent evaluation by multiple specialists, and it was noted that he had the presence of a systemic inflammatory process. However, comprehensive autoimmune serologies were unrevealing. Due to concern for systemic vasculitis, he underwent a sural nerve biopsy. This is shown here, and biopsy demonstrated the presence of inflammatory cell collections surrounding and invading an epineural blood vessel. This was consistent with a histologic diagnosis of small and medium vessel necrotizing vasculitis. Another sample from the nerve biopsy is shown here, again demonstrating evidence of inflammatory cells invading and surrounding epineural blood vessels. Based on these findings, the patient was diagnosed with polyarteritis nodosa. Moreover, due to his hypertension, he underwent catheter-directed renal angiogram, and this demonstrated the presence of microaneurysms and arterial branch occlusions, again consistent with the clinical diagnosis of polyarteritis nodosa. He was treated with immunosuppressive therapy, including high-dose glucocorticoids and cyclophosphamide, for a duration of approximately 2 years. This eventually resulted in clinical remission. However, 2 decades later, at the age of 29, this individual presented with new onset neurologic symptoms and was diagnosed with a right pontine ischemic cerebral infarct. Again, he had elevated inflammatory markers, and following comprehensive evaluation with our colleagues in neurology, was given a diagnosis of central nervous system vasculitis, likely related to his known diagnosis of polyarteritis nodosa. He was again started on immunosuppressive therapy with glucocorticoids and rituximab. However, he unfortunately continued to experience intermittent neurologic symptoms and subsequently was diagnosed with a new ischemic cerebral infarct involving the left cerebral peduncle. This is demonstrated here on this axial image from an MRI scan, showing the presence of T2 signal here in the left cerebral peduncle. Lumbar puncture and cerebrospinal fluid analysis were unremarkable, and a catheter-directed cerebral angiogram shown here was normal. In addition, MR angiogram did not show evidence of vessel wall enhancement. The patient's immunosuppressive regimen was intensified. However, he unfortunately continued to experience musculoskeletal symptoms and ongoing low-grade fever. Due to the concern for possible deficiency of adenosine deaminase 2, he was evaluated by our colleagues in medical genetics. Genetic testing was performed and identified a single mutation, pathogenic variant in the ADA2 gene, noted here with an arginine to glutamine substitution. However, this was a heterozygous paternally inherited pathogenic variant and did not establish a genetic diagnosis of DADA2. Due to ongoing clinical concern for this diagnosis, additional variants that could have been missed were evaluated for. An exon-level oligoarray was performed, and this detected a deletion encompassing the first exon of the gene ADA2. This deletion was noted to be inherited from his mother, confirming that the pathogenic variants were in opposite alleles in this affected individual. Moreover, he underwent ADA2 enzymatic testing, and this was markedly decreased at a level of 0.2 microunits per ml, markedly diminished compared to healthy controls. So in conclusion, this individual was diagnosed with deficiency of adenosine deaminase 2. This is typically an autosomal recessive disease caused by biallelic mutations in ADA2. However, in a small number of patients, DNA sequencing may reveal only one pathogenic mutation, thus resulting in potential delayed diagnosis. Therefore, these patients should be investigated further for additional genetic variants, such as deletions or mutations, which are often beyond the scope of routine genetic testing. Of course, to a rheumatologist, it's very important to distinguish idiopathic polyarteritis nodosa from DADA2 because of its impact on patient management. Indeed, in patients with DADA2, TNF inhibitors have been shown to reduce stroke activity, to improve symptoms, and to normalize acute phase reactants. Indeed, following the diagnosis of DADA2, our patient was transitioned to treatment with a TNF inhibitor. Specifically, he was treated with adalimumab, which resulted in the resolution of his fevers and joint symptomatology. Fortunately, at the time of last follow-up, he has not had further cerebral ischemic infarcts. Again, in conclusion, DADA2 should be suspected in individuals with vasculopathy or polyarteritis nodosa, particularly if presenting with ischemic stroke. Molecular analysis of the ADA2 gene should include sequencing, as well as specific testing for deletions and duplications, since exome sequencing may not be the optimal test for this disease. In addition, ADA2 enzyme level should be obtained in patients with clinical features whenever initial genetic testing is inconclusive. I thank you for your attention.